All right, I'm gonna give you a quick, simple, nothing super in depth. You look at the Vigileo and you figure out, on a most basic sense, it's either looking like a cardiogenic situation, maybe a septic shock situation, or maybe a hypovolemic situation. The Vigileo is just a tool. It's not to be taken literally every single time. You also have to judge factors like, is this patient breathing on their own? Are they getting adequate tidal volumes with every breath? Are they in a normal rhythm in a normal rate? Are they paralyzed? Ideally, either well sedated or paralyzed, because that's going to be the most accurate numbers. If they're not well sedated or not paralyzed, or they're breathing over the vent a little bit, some of these numbers may be off. Now, if those numbers are extremely high or extremely low, there may be some validity to them, but once again, use clinical factors, clinical interpretation, and clinical evidence to define those numbers. For example, if somebody has a really low cardiac output and a really low stroke volume, and their blood pressure's in the tank, and they're sweaty and pale, and their echo that they had recently showed an EF of 20 to 25%, then yeah, what you're seeing probably is in fact cardiogenic in nature. But if the person has a perfect echo, they don't have any physiological symptoms that you can see or signs that you can see, then it may not be cardiogenic shock just because the stroke volume is low. It may be the arterial line waveform. It may be that the arterial line isn't placed in the exact spot it needs to be. Maybe the patient's bending their wrist. There's a lot of factors to consider there. But I'm going to teach you in the ideal situation with the ideal factors in place, kind of the quick and dirty. All right, so we'll start with understanding SVV. I feel like that's one that if you understand SVV, at least the way that I think about it, it can be very helpful. So right here you have a normal vena cava, right? The vena cava is inside the chest cavity, and as you take a breath in and a breath out, you get an increase and a decrease in pressure, right? That increase and decrease in pressure has an effect on the circumferential pressure of the vena cava. It's either going to collapse the vena cava if the vena cava is empty or has less fluid in the venous system, or the vena cava is going to just go a little bit, but for the most part stay pretty plump, right? So with a breath in and a nice plump vena cava with good volume in the body, you're going to see very minimal collapsation of that, right? The vena cava supplies the right heart, which in turn gives you your stroke volume, gives you your preload, right? And then gives you your afterload, right? Better preload, better afterload. It's just the rubber band theory, Starling's law, whatever you want to call it. However, if your vena cava is depleted of fluid and you take a deep breath in and it's depleted of fluid, it's going to collapse a lot. It's going to reduce the amount of blood volume that can get to the right heart, so reduce your preload, which in turn reduces your afterload, which in turn reduces your blood pressure. So that could be somebody who has a low fluid volume in their system. This can be seen on an arterial waveform as stroke volume variation. Usually you see it with breathing, right? This is somebody on a ventilator. Every time you see a breath, you'll see a little bit of change in the height. So right here, you can see an arterial waveform where the peak of every few beats is much higher than the peaks in between. And the difference between the higher peaks and the lower peaks is measured as stroke volume variation. Because remember, the peak, once it hits the top, that's the overall volume. And the next beat being shorter is a smaller volume. The difference between the two volumes is the variation of the volume. Now, as that gets greater, you have a higher percentage of change. That's measured as SVV. So SVV is usually 13% variation or less. We're okay with that. That's normal. That's normal physiology. But if that SVV, probably in this case, would be closer to like 25% change or even higher, then it's likely that there is a fluid volume deficit in this patient. They have less blood volume in their venous system, whether it's from third spacing, whether it's from bleeding, whether it's from dehydration, or maybe it's septic shock and they're actually third spacing all of the fluid into the interstitial space. Whatever the case may be, what we can try to come to the conclusion of here is that maybe there's a little less fluid volume in there. Another way that you can tell if someone has less fluid volume is the stroke volume, right? Whenever somebody is laying flat and you lift their legs, you would expect the stroke volume to go up. I think it's somewhere between 10 to 15%. Don't quote me on that, but it's significant. You know, if their stroke volume was 40 and you lifted up their legs and you held them there, it's called the straight leg raise test, right? You held them there for, 30 seconds to a minute, and you see their stroke volume creep up a significant amount. Let's say it goes from 40 to 60. Okay, that's a positive sign that somebody is dehydrated, right? That means that you're actually pouring venous fluid back in, right? You're pouring that blood back in from the legs into the core, and it's helping the preload of the heart, and the heart starts to get a better stroke volume, okay? You lay their legs flat, their stroke volume slowly creeps back down. That fluid has returned from the most of the core and just went back down to the extremities. What does this patient need? Well, they got low hemoglobin, they need blood. If they're in septic shock, then they need fluids. If they're dehydrated, they need fluids, potentially pressors. But the overall consensus is whatever the fluid depletion is, we need to replete that fluid, okay? So that, in a nutshell, is how SVV works. So, cardiogenic shock, what are some of the symptoms that you would see quick, or the signs that you would see on the monitor really quick? Your patient's hypotensive. That's the key thing. All of these scenarios, the patient's hypotensive, okay? If they're not hypotensive, this isn't going to tell you a whole lot. So, cardiogenic shock, you're going to see a decreased stroke volume, a decreased cardiac output, cardiac index. So, a normal cardiac output is 4.0 to around 8.0. A normal cardiac index is, I believe, 2.5 to 4.0. So if this person has a cardiac index that's low and their stroke volume of 60 to 100 is less than that, let's say they have a stroke volume of 40, and that makes their cardiac index like 1.8 and their cardiac output like 3.0, but everything else is relatively normal. Let's say their SVV is 10, but there's an equation that occurs with SVR, right? Systemic vascular resistance. A lot of times what you'll see on the monitor, at least, is the SVR will be elevated. It'll be 1400, 1800, 2000, right? So because either A, it's the equation that's causing it from the calculation, or the way I like to think about it is if the heart's not pumping adequately, the vascular system is clamping down to try to assist the heart. And so if you think about it like that, the SVR is the clamping measurement. The more clamped, the higher the number. The more relaxed the vessel is, the lower the number. So the vessels are tight, at least on the SVR monitor. The SAV is normal. The cardiac index output are low and the stroke volume's low. This patient needs an echo. Let's find out if they have a low EF. They probably need something along the lines of an inotrope like dobutamine, dopamine, milrinone, something like that. Septic shock. I like to think about this less as septic shock and just general distributive shock. What distributes your blood from its origin to all the tissues and organs that need to be perfused is the highways are the vessels, right? So the distribution highway is the vessel. If the vessel itself is dilated, then the overall pressure in the vessel is going to drop, okay? If you take a garden hose and you just turn it on, it'll just droop right out of the garden hose. But if you put your finger over the top, because you're reducing the overall diameter of the tip of the hose, you're actually going to shoot the pressure up in the hose and you're going to get a stream much further, right? Same concept in the bloodstream. If you have a blood vessel that is wide, you're going to have low pressure, and as the vessel clamps down, let's say you give them vasopressors, as it clamps down, it's allowing that pressure to pick up in the vascular system. It's going to increase the return to the heart, and it's going to increase the stroke volume and the afterload and the blood pressure. So people who are in septic or distributive shock, they're either leaking or they're vasoplegic or vasodilated. And the vasodilation is a component of all of the byproducts of the infection, the tissue breakdown, right? It's causing, one, the actual vessels themselves to become damaged, and as they become damaged, fluid leaks out of the vessel and into the interstitial space. We see this as peripheral edema. This is usually more of a later stage. Early stage, you start to see a little bit of vasodilation. So what's the definition of septic shock? It's you have someone who's got a low BP with a source of infection, and you have evidence in your labs, and you have evidence in your blood cultures, or you have physical evidence that you can see someone has an infection, like you do a chest x-ray and they have pneumonia, or there's a giant wound on their leg and it's just purulent, right? And they have a low blood pressure. So in order to call it septic shock, you have to treat the underlying potential for hypovolemia, right? Either they've third spaced already, or maybe they're dehydrated because the infection has made their appetite lower and they haven't eaten or drinking anything in a period of time. So then you need to give them fluids, right? You give them 30 mLs per kilo bolus, right? So you give that patient this fluid bolus, and then their blood pressure gets better, or it doesn't. But let's say it does get better. If it returns back down to a low blood pressure, or it stays a low blood pressure, you now have defined septic shock, right? Source of infection, low blood pressure, you've given fluids, and then they're still hypotensive, whether it's a few minutes later or right away. Now this person needs vasopressors, because remember, the vasodilatory issue with distributive or septic shock is still happening. You've filled the tank, but now you have to squeeze the vessels to raise the pressure. Over time, these vessels that are damaged are going to repair themselves, and they're going to get better at doing their job, and they're going to start contracting on their own in the appropriate ratio to raise the pressure as a normal human should. And that's when your pressor demand starts to drop, and you start to lower your dose over the next day or so, and you get them off pressors. It's because the blood vessel itself is actually doing its job again and starting to come back. All right, so that is septic shock. What does that look like? Septic shock can look like a few things, but typically what you'll judge for septic shock is a normal cardiac function, normal cardiac index, normal cardiac output. Maybe their stroke volume's a little on the lower side. It could be, or it could be completely normal, because remember, if they're dehydrated or they have low fluid in their vascular system, then the stroke volume could be a little on the lower side until you start giving them those fluids. But the bigger thing you're going to see is the SVR. The SVR, Alexa, stop. The SVR is going to be low, and that low SVR, remember 800 to 1200 is normal, be like 600, right? And you're going to see an otherwise potentially a high SVV. Let's say it's going to be like 18%. Well, when you give this patient fluids, you're going to see the SVV go down to normal range. The stroke volume should go up to normal range. But the big thing here is the SVR. It's going to remain low. And then once you give them vasopressors, it's going to go back up to a normal range. Let's say 800 to 1200. So that's what we're looking at for septic shock. We see a low blood pressure, a source of infection. We give them a fluid bolus. They continue to be hypotensive and in shock. You start vasopressors. On your Vigileo, you're going to see a stroke volume that may be a little low, but maybe normal. An SVV that may be a little elevated or maybe normal. But the SVR is definitely going to be low, because that is the vasodilation. Remember, lower SVR numbers, lower vasoconstriction. Higher SVR numbers, more vasoconstriction, or the tone of the vessel is better. So moving on to hypovolemic shock, it's basically SVV is high. High is dry, you'll hear that. That refers to SVV. Let's say it's 30%. because we have a high variation. And your cardiac index, output, and maybe even your stroke volume are on the border of low or normal. They could be either, but your SVV is going to be through the roof. And the cardiac index, output, and stroke volume may actually be just fine, but what you may see instead as a compensatory measure from the body to try to help fix the situation is you're going to see an elevated heart rate commonly, unless they're on beta blockers or something like that. But a normal physiological response to low blood volume is increased heart rate to try to compensate. You may see some alteration to the cardiac index, output, and stroke volume, but they may be fine. It may be compensating really well. You may have a heart rate of 120. You may have a MAP of 45, and this patient has an SVV of 30, right? And the SVR may be normal, maybe 1,000, okay? But the big thing you're seeing is the SVV. You can also do the straight leg raise in this situation to see if the stroke volume goes up, okay? So now, this patient you give fluids to, let's say you give them a 1 liter bolus, right? Or a 2 liter bolus, whatever seems more indicated. And then their SVV goes from 30% down to 18%. And their MAP goes from 45 to 55. Well, guess what? You're on the right track, okay? As long as this patient continues to improve with fluids, you're on the right track. Your SVV is super high, everything else looks kind of normal. Maybe the cardiac stuff is a little on the lowish side or even low normal. But as you improve their SVV and as you fill the tank, you may see the cardiac index, output, and stroke volume just go right on up because you're resupplying the right side of the heart, the preload, and because of that, your blood pressure improves. But the sign that you'll see on the monitor is that the SVV starts to go down, and on your arterial line waveform, what you'll actually see is a more normalized peak, where everything is a little more normalized and the variation between the peaks is minimal, and instead of being closer to like 30%, now it's closer to 13%.